Good afternoon. My name is Dr. Christopher Sinigliaro, and thank you for inviting me to speak at the 60th Annual International Spinal Cord Society Annual Scientific Meeting. Today, I would like to present findings from a study entitled Applying a Novel Multivariate Biomarker Panel to Determine Cardiovascular Disease Risk in Persons with Chronic Spinal Cord Injury. I have no conflicts of interest to declare. In persons with chronic spinal cord injury, cardiovascular disease occurs earlier in life, has a prior prevalence, and is a leading cause of mortality. It is well documented that cardiovascular disease contributes to approximately 6% of all deaths in individuals with SCI greater than 30 years post-injury, and approximately 35% of deaths in individuals with SCI over the age of 60. Conventional clinical risk factors and scores are commonly used to predict major adverse cardiac events. However, these have been demonstrated to be time and labor intensive and lack sufficient sensitivity and specificity. Furthermore, advanced imaging such as coronary artery calcification scoring and coronary angiography are expensive and require significant exposure to ionizing radiation. The purpose of this current report is to determine in a cohort of subjects with SCI the relationship of a low-cost and low-risk multivariate biomarker blood test and compare these to two conventional approaches for predicting cardiovascular disease events. We performed a cross-sectional study on 68 men and 9 women, non-ambulatory participants with chronic SCI, greater than 12 months duration, for the following assessments. A Framingham Risk Assessment score was calculated utilizing the standard clinical risk factors: impaired fasting glucose, hypertension, obesity, smoking, sedentary lifestyle, family history of cardiovascular disease, and dyslipidemia. In addition, coronary artery calcification score, CAC score, was then obtained with the number of participants with CAC scores greater than 0 Hounsfield units identified. The conventional CAC and Framingham Risk Assessment 10-year scores were compared to the Heart CVE biomarker blood test. The Heart CVE biomarker blood test is an easy to obtain, at low cost, low risk, and accurate multi-protein blood test that can predict the 1-year risk of heart attack, stroke, or cardiovascular death. The Heart CVE blood test is a novel, validated lab-developed test that has been approved as a multi-protein biomarker blood test and was performed in the current investigation to predict the risk of having a cardiovascular disease event over a 1-year period. The multi-protein panel consists of the following biomarkers: N-terminal pro-B type natriuretic peptide, kidney injury molecule 1, osteopontin, and tissue inhibitor of metalloproteinases 1. This multi-protein panel was then applied to a proprietary algorithm using a 10-point score known as the CVE score, and then was further stratified into 3 levels of risk for having a major cardiovascular event: 0 to 3 being low risk, 4 to 6 being moderate risk, and 7 to 10 being high risk. The Heart CVE blood test is well validated through both internal and external methodologies. In an internal validation study performed by McCarthy et al., data from participants enrolled in an observational cohort study entitled Catheter Sampled Blood Archive in Cardiovascular Disease, performed at the Massachusetts General Hospital, MGH, underwent coronary angiography and had blood samples analyzed for the Heart CVE multi-protein biomarker blood test. In this internal validation group, a receiver operating characteristic curve was performed using cardiac catheterization as the classification outcome to determine disease. And with the ROC curve, there was identified a single 2-risk level cutoff value with a negative predicted value of 93% and a positive predicted value of 28%. Furthermore, a 2 cutoff 3-risk level ROC curve analysis was also completed and yielded optimal heart CVE risk score cutoff values with a negative predicted value of 97% and a positive predicted value of 36%. In an external validation study performed by Newman et al., blood samples from the biomarkers in acute cardiac care study population from the emergency department at the University of Hamburg, Germany, validated the heart CVE multiprotein biomarker blood test against cardiac troponin. As you can see, in the external validation study, the ROC curve analysis yielded an area under the curve of 0.86, which was even higher than the internal validation obtained from Massachusetts General Hospital, demonstrating the heart CVE blood test is well validated through both internal and external methodologies. So why do these proteins predict cardiac events? The 4 proteins that comprise the heart CVE blood test are biomarkers that identify different components of cardiovascular health. Osteopontin identifies plaque inflammation and calcification, while TIMP1 identifies plaque eruption and extracellular matrix degradation. The NT-proBNP identifies myocardial ischemia, damage, and stress. And finally, the KIM1 identifies cardiorenal syndrome. From this work validating the heart CVE blood test, a Kaplan-Meier survival curve was obtained from Cox proportional hazard analysis. The curve depicts time to incident major adverse cardiac event stratified by CVE risk levels, low, intermediate, and high. In the lowest risk group, using the CVE risk score, we can see that the group remained relatively stable 12 months after into observation. However, in the intermediate risk score group, major adverse cardiac event increased to more than 5%. And in a high risk score group, major adverse cardiac event exceeded 20% after the 12-month period. There were 77 participants in our study that met the following inclusion criteria: males 45 to 75 years old with SCI greater than or equal to 5 years duration, females 50 to 75 years of age with SCI greater than or equal to 5 years duration, stable SCI, all levels of injury, international standards for neurological classification of spinal cord injury, A to C. All participants were non-ambulatory, defined as not able to weight bear for more than 10% of the day. Exclusion criteria included acute medical illness, pregnancy, chronic debilitating disease, atrial fibrillation, coronary atherosclerosis, cardiac pacemakers, anti-lipid therapy, and a history of percutaneous coronary angiography with stent replacement. The characteristics of our SCI cohort are presented. Our SCI study participants were between 44 and 72 years of age, with a mean age of 55, were primarily male. Mean duration of injury was 21 years and ranged between 4 and 49 years. And greater than 80% of participants had motor complete lesions, with all participants being non-ambulatory. The results of our analysis indicated that of the 77 SCI participants, 37, 48%, had CAC scores greater than 0, with a mean CAC score of 200 Hussenfield units. These values are computed only for those with positive CAC scores. And we can see that 13 or 35% of the participants had CAC scores greater than 100 Hussenfield units, which puts them at the moderate risk level. The results of Framingham Risk Assessment Score revealed that 25 of the 77, 32% participants had scores greater than 10%. The results of stratifying by the 3 risk levels indicated that 52 of our 77 individuals fell within level 1, lower risk, with scores between 1 and 3. 24 fell in the level 2, moderate risk, with scores between 4 and 6. And 1 individual fell in the level 3, higher risk, with a score between 7 and 10. When stratifying our CAC score and 10-year Framingham Risk Assessment Score by cardiovascular event risk levels, we see on our x-axis, we have the cardiovascular event 3-level risk classification. And on the left graph, our CAC score, we can see that there was a significant increase from the level 1 to the level 2 classification. So from low to moderate risk, going from 15% of individuals above 100 Hussenfield units to 38% of individuals in the level 2 classification above 100 Hussenfield units. A similar trend was observed with Framingham Risk Assessment Scores, with 32% of individuals above the 10% Framingham Risk Assessment Score, and at the level 1 risk, and 39% of individuals above the 10% or greater Framingham Risk Assessment Score in the level 2 classification. However, this trend was not significant for the Framingham Risk Assessment Score. The conclusion of our findings is that the majority of the SCI cohort was categorized as low risk for CVE, regardless of which of each of the 3 scoring systems for assessment of CVD risk was used. CAC score increased significantly between levels 1 and 2 of the CVE risk assessment tool. And there was a trend for an increase in 10-year Framingham Risk Assessment Score between levels 1 and 2 of the CVE risk assessment tool. There were several limitations of our study, the primary one being relatively small sample size, very few subjects in the CVE high risk category, only 1, leading us to make it impossible to stratify by level and duration of SCI. The effect of SCI-specific risk factors could not be tested, such as degree of physical activity and level of depression of HDL cholesterol. Furthermore, there was a large variability among the tests employed in the length of time to predict the occurrence of a cardiac event, with the CVE score predicting the 1 year and the CAC and Framingham assessment score predicting much greater lengths of time. So direct comparisons, even though were made, were not entirely appropriate. Future work should validate cardiovascular event scores against gold standard measures of cardiovascular disease in an SCI population, as was performed in a general population sample in the studies that were referenced earlier. Here are my references cited, and thank you very much for your time, and I'd be happy to answer any questions.